thrilled to have we're really thrilled to have an update from two of our grant awardees. And we'll say a little bit about the program that we've established through the Johns Hopkins Gupta Kunsky India Institute. And so thank you for all of you who got up early this morning to join us in the United States and are staying later on a Friday night in India. All right, so a little bit about the Breakthrough Grants objectives. So in 2022, we established the program with a few sort of key objectives, really wanting to have a mechanism by which we could facilitate collaboration of scientific inquiry, provide some initial seed funding, and support the development of new partnerships and research collaborations that are equitable. As well as have a mechanism to provide some mentorship and training with an emphasis on, as part of these grants, to identify more seasoned investigators and early career researchers. And so, as part of a process, we had our first release of an RFA, and you can see here some of the images of our funded researchers, ranging from looking at TB and mental health, and you'll hear from a few of the researchers this morning, and things like climate change and policy related to work done with the government of India, as well as looking at sort of new ways of doing modeling for TB. So on to the next slide. So the way that these are designed is we basically have we released an RFA, and it requires a Johns Hopkins investigator along with an Indian institutional investigator to come together and propose a project. We've sort of done it in themed sessions, and we've awarded about 2 to 3 research proposals at around anywhere from 50 to $60,000 each. Some of our projects have actually been co-funded by the Indian institution. So on the U.S. side, Johns Hopkins Gupta Kunsky India Institute provides funding for the U.S. investigators, and on the India side, the Indian investigators are funded. And we have these proposals reviewed using the criteria shown here on the right, both by Indian and U.S. JHU sort of committees that are put together to help judge the proposals for funding. Next. And you can see here on the left some of the partnerships that have been forged through the release of these breakthrough grants. They include Ashoka University, Koita Digital Health Center at IIT Mumbai, the Public Health Foundation of India, Fortis Hospitals, D.Y. Patil, the Department of Biotechnology, and Tata Medical Center, as well as so far we've had grants submitted by School of Medicine and School of Public Health that got awarded. We also had several others that from other parts of the university that had submitted, but these are who've been awarded so far. And we had originally, when we released this, we first started on non-communicable diseases as a RFA. Then we went to and we then had infectious diseases, climate change, artificial intelligence. And so these have been some of the thematic areas. And so far, we've generated over $300,000 worth of collaborative funding. Next. Some of the key learnings from the program to date include that there's a lot of interest in having data science and AI collaborations. And so that's really an area where we're going to further expand our Breakthrough Grants program. And then, of course, health research has remained popular, and we want to, after this program and webinar, we're looking forward to having feedback about what will be really value add. But other learnings include that a lot of the funding that we get for these programs allow us to hire fellows and research assistants, that the co-funding amplifies the investments in a sort of bilaterally funded mechanism, which is really great. And then we're sort of tracking the impact, the ROI, if you will, the return on investment of how the seed grant funding is helping investigators to go on to get larger sources of funding. Next. So without further ado, and the reason you're really here to listen to some presentations, our first presentation is titled Formative Assessment for Peer-Led Mental Health and TB Services Integration in India. And it's a collaboration between Christopher Kemp, who's an assistant scientist in the Johns Hopkins Bloomberg School of Public Health. And he has been working with Nishi Suryavanshi, who's a senior behavioral scientist and deputy director of the Center for Infectious Diseases in India, that's based in Pune. The two of them will be our first presenters. And then the second presentation will involve maternal metabolites in pregnancy and child growth in India, which will be presented by Sara Benjamin-Neelon, who is in the School of Public Health and Health Behavior and Society and the director of the Lerner Center, and is the Helaine and Sidney Lerner Professor. So without further ado, Megashish will head over to the presentations.
Thank you, ma'am, for that insightful remarks and giving an overview of the institution. I now hand over the presentation to Dr. Nishi Suryavanshi as she shares insights from her work that examines the correlation between mental health and tuberculosis. Dr. Nishi Suryavanshi is a behavioral scientist and serves as the deputy director for the CIDI from Johns Hopkins University. So, ma'am, over to you. We have 20 minutes for your presentation and 5 minutes for the question and answer. And I request audience to keep pouring in their questions through the chat option, and then we'll take them after the presentation. So, without further ado, over to you, ma'am.
Thank you, Megashish, and thank you, Amita, for the introduction. Let me share my screen. Okay. Can you see my slides?
Yes, we can. Just if you could put them into presenter mode.
These are not in presenter mode?
It's in the, you just have to change the mode setting.
Is it now in presenter mode?
Yep.
Okay. Okay. Good afternoon, good morning, everyone. And thank you for joining us today. I'm excited to present the findings of our study, Co-Designing Peer-Led Mental Health and Tuberculosis Services Integration in Pune, India, which is led by Dr. Christopher Kemp and myself. And it is part of the TB Aftermath study, which is an ongoing post-TB active case finding study. So as we know that tuberculosis remains a major public health concern in India with high notification rates across the states. In Pune, the district TB center and tuberculosis unit serves a large urban and rural population, underscoring the need for effective interventions. And mental health is equally pressing. 1 in 7 people in India face mental health conditions. Yet there is a severe shortage of mental health professionals. And the National Mental Health Survey actually recognized critical gaps in care access, highlighting the need for integrated solutions. So it is also a well-known fact that people with TB are at an increased risk of depression and anxiety symptoms. Integrating mental health care into TB treatment has been shown to improve the outcomes for both these conditions. And our study took a co-design approach, engaging people with lived experience of TB and mental health challenges to ensure acceptability and sustainability. And our study objectives were to identify key barriers and facilitators and develop a menu of implementation strategies for TB and mental health integration. So our study was actually conducted in two parts. First, we conducted key informant interviews with TB survivors with lived experience of mental health conditions, their family members, TB providers, and mental health providers in Pune to understand the key barriers and considerations for TB and mental health integration in this setting. We then held the focus group discussions in second part with some of those key informant participants to engage in implementation mapping, and which is around designing the strategies for care integration. And our study, as I mentioned, was nested within the TB aftermath trial. And we sampled a mental health and TB provider from DY Patil Hospital, where the study was conducted, and other clinics in Pune. And we sampled the TB survivors with lived experience of mental health conditions from TB aftermath study, who were found to have depressive and anxiety symptoms. And data analysis was guided by consolidated framework for implementation research. And in our first FGD, we focused on presenting AIM-1 results and achieving consensus on key barriers and facilitators to TB and mental health integration. And we then used those results to propose some strategies and then work to achieve the consensus on those strategies in our second focus group discussions with the same participants. So coming to the results of our AIM-1, we interviewed 25 people that includes 10 TB survivors with lived experience of mental health condition, 5 family members, 5 TB providers, and 5 mental health providers. Our findings highlight several key barriers, including stigma, a lack of awareness about mental health, and limited availability of services. Participants emphasized the importance of family support, yet the stigma often prevented these individuals from seeking care. And as one of the survivors shared, I did not show it to anybody because my family members said that disease is a disease and there is nothing like a mental disease. So the awareness is really not there that these mental health conditions do exist. So participants also emphasized that several barriers and highlighted these barriers to care seeking for mental health care, including lack of awareness that counseling was available as an alternative to psychiatric medicines. And these are some of the quotes showing those. Participants also offered several suggestions for care integration, including raising awareness, adding regular screening and counseling about mental health at the time of diagnosis and during TB treatment, and engaging TB survivors in support and treatment. So we used these thematic results to develop journey maps, both as a way to summarize the data and to help the program designers think through the issues faced by the patients. And these are hypothetical people, not the real participants. However, the journey map represent the experience of a real female TB survivor who also faced depression and anxiety symptoms during her TB treatment. And at the time of diagnosis, she experienced significant distress, which is worsened by stigma and lack of emotional support from family. And she described feeling isolated and uncertain about her future, even after completing her treatment. And similarly, this journey map follows the experience of a male TB survivor who struggled with anxiety and depression following his TB diagnosis. And to manage his mental health condition, he started consuming alcohol, resulting missing TB medications. His journey highlights the role of community perceptions, stigma, and fear in shaping his mental health experiences. In AIM 2 for focus group discussions, we engaged 5 survivors, 1 family member, and 5 providers for implementation mapping. So our focus group discussion participants emphasized the importance of structured multi-level interventions. As one TB provider puts it, stigma is the main factor, and for stigma, we have to do long-term health education in public. That is the only solution. All participants of FGDs agreed on the need for mental health and TB integration to improve adherence and recovery. And other key recommendations included routine mental health screening at the time of TB diagnosis and follow-ups, peer-led support groups, and training TB providers in mental health care. The stakeholders, they also agreed that co-locating TB and mental health services would improve access and treatment outcomes, and especially for the rural area, they also mentioned like engaging the ASHAs and TB survivors would be helpful. So we were able to develop a menu of strategies for TB and mental health integration, including awareness and stigma reduction, an integrated care model that combines screening, peer and or healthcare worker-led counseling, tailored consideration for areas with less healthcare worker access, and a plan for follow-up. We also thought through the strategies for supporting patients and their family members, and implementation strategies, including training and monitoring and evaluation. So our findings reinforce that embedding mental health support within TB programs is both feasible and necessary. The study underscored the importance of awareness and stigma campaigns. And given India's shortage of mental health professionals, peer-led and health worker-supported interventions offer a scalable solution. And future research should assess a long-term feasibility, acceptability, and scale-up strategies for sustainable integration. While our study provides important insights, there are some limitations. These findings are actually based on a single city, and mental health conditions were assessed using varied methods. Additionally, the participation constraints, especially due to stigma, it impacted our recruitment, and we faced challenges in recruiting these participants. Next step include like piloting our integrated TB and mental health strategies, testing their feasibility and effectiveness, and using patient journey maps to refine implementation approaches. And as we move forward, continuous engagement with the stakeholders will be essential to ensure these models are sustainable. So with this, I would like to acknowledge our study team, participants, and institutional partners for their contributions to this research. Special thanks to Johns Hopkins Gupta Klinsky India Institute for support, financial support, and our collaborators in Pune. Thank you for your time, and I look forward to your questions and discussions. And I see Dr. Kemp is also on the call, so please feel free to reach out to me or Dr. Kemp or any of the co-authors via email for any additional or detailed information on the study. Thank you so much.
Well, that was terrific. Thank you so much, Dr. Suryavanshi. Really very interesting and really important to actually use the qualitative data to understand things like patient journeys and sort of perspectives from providers, patients, families, healthcare workers, to really understand what kinds of interventions can be designed within program. And perhaps you could say a little bit about what your next steps are using these data. What are your plans for expanding the work, either to you or Dr. Kemp?
Hey everybody, Nishi, you're on mute if you're talking. Otherwise I can jump in.
Yeah, please go ahead. Yeah, I was on mute. Please go ahead,
Thank you.
Christopher.
Thanks, Nishi, for your fabulous presentation. And sorry, everybody, I figured I might not be the best person to talk today. It's 4 a.m. where I am. But I am grateful to be here. Just to say that we're pursuing funding for a larger trial of integrated care model, peer-led integrated care model with our partners in Pune at this point. So that's where we're moving towards, so at an R01 level funding.
Fantastic. That's great to hear. And good luck with that. So any questions from the audience? Feel free to raise your hands if you have any questions. All right. Well, it was a very clear presentation, and it looks like there are no specific questions for you both. So congratulations on your work, and look forward to you garnering a successful new study.
Thank you for the support. Much appreciated.
Thank you.
All right. Well, we'll go on to the second presentation, which oh, go ahead.
Yeah. So I can introduce the next speaker, ma'am. So the next presentation, which explores the correlation between maternal metabolites and maternal child health. For this, I welcome Dr. Sara Benjamin-Neelon, who is a professor and the director at the Lerner Center at the Johns Hopkins Bloomberg School of Public Health. So over to you, Dr. Sara.
Thank you. Are you all able to hear me okay?
Yeah, we can hear.
And are you seeing my slides?
Yes, we can.
Okay, perfect. I've been having technical difficulties this morning. I've been joining by phone, so thank you all for your help getting me into this meeting. It's a small accomplishment, but an important one. So my name is Sara Benjamin-Neelon. I'm a professor in health behavior and society and international health in the School of Public Health. So I'd like to first thank the funders who are all present on this meeting today. The title of our project is Maternal Metabolites in Pregnancy and Child Growth in India. And this is a picture of the PIs here, myself and Dr. Giri Babu at the Public Health Foundation of India. We also have some team members at the University of Colorado School of Medicine, formerly at the School of Public Health at Johns Hopkins. And then we have team members at the India Institute of Public Health, Bengaluru, and the Camp, which is our lab that performed the metabolites assay. So we had two study objectives. The first was to increase our understanding of child non-communicable disease risk very broadly and development through exploration of the maternal metabolome. We also aim to fortify the existing collaboration between the School of Public Health and the Public Health Foundation of India by pulling in new collaborators and addressing novel research questions. We had three aims of this research. The first, and these evolved a little bit over the study period as we pulled in new colleagues and collaborators. The first was to assess associations between maternal blood metabolites in pregnancy and preterm birth as our outcome. We next wanted to assess association between metabolites in pregnancy and maternal depression in the postpartum period. And then finally, we aim to assess associations between metabolites and child growth, both at 1 year and 5 years, and then child development at 5 years. So that's gross motor and neurological development. So a little bit of a brief background, since our two presentations are so different. The metabolome is a downstream product of the genome and consists of low molecular weight molecules or metabolites in cells and tissues. And these are required for growth, maintenance, normal function, and change. Now, metabolomics was first defined in the 1990s, but some would argue it dates back to the 1950s to describe approaches to measure metabolites present in a given physiological state. So in this case, pregnancy. Now, prior research has demonstrated associations between metabolites during pregnancy and gestational diabetes, hypertension, and gestation length, which is what we're interested in. One recent study examined almost 3,600 pregnant women and identified 54 metabolites, maternal metabolites associated with accelerated growth during pregnancy. And then more recently, Kinship et al. Assessed vaginal metabolome among 152 full-term and 80 preterm births in Black and white women in the US, and they identified 4 metabolites higher in preterm births. And this study really is closer to what we did with this research, so close in sample size and close in outcome. So we use data from the MASTI study. These are our study site locations on the map to the right. I'm going to give you a very brief history of MASTI. MASTI stands for Maternal Antecedents of Adiposity and Studying the Transgenerational Role of Hyperglycemia and Insulin. And I assure you, I did not come up with that acronym. That is a mouthful. Now, this is a prospective birth cohort of mother-infant dyads. Women were recruited from public hospitals, tertiary care hospitals, urban primary health centers, and maternity homes. To be included, women had to have a singleton pregnancy, no congenital abnormalities, be between 14 and 36 weeks gestation, and not have a diagnosis of diabetes or Hep B, and not be HIV positive. So we started this study back in 2016, and it is ongoing. And at the time, Dr. Babu and I were colleagues. We had been introduced by a mutual friend, Sanjay Kinra, at the London School of Hygiene and Tropical Medicine. And Giri Babu and I were both interested in starting our own cohorts. And so in collaboration, we started 2 cohorts. One is MASTI in India, and the other one is my birth cohort, which is called Nurture in the southeastern US. Now, Dr. Babu has been much more successful at maintaining his cohort because it's still ongoing. Mine wrapped up a few years ago when I left Duke University Medical Center and joined Hopkins. So the primary exposure in MASTI was oral glucose tolerance test. The outcome was, this was in pregnant women, and the outcome was infant skin fold thickness, weight, length. Now, this is what MASTI was interested in, although for this project, we have a slightly different research question. They were interested in examining gestational diabetes and offspring health outcomes. So just to give you a very brief history, MASTI started in 2012 when Dr. Babu and I first started having these conversations, initially with funding from Wellcome Trust, when I was one of his mentors on his initial proposal for a fellowship. And over the years, MASTI blossomed into a full-blown cohort. So we collected a number of maternal measures just to give you an idea of all of the various measures and assessments we were interested in pregnancy, including diet, which is one of my areas of focus, social support, anthropometry, blood pressure, hemoglobin, socioeconomic status. We also assessed a number of infant offspring measures, including delivery information, developmental milestones, and feeding. So initially, we screened 5,694 pregnant women, went through various stages of attempting to conduct oral glucose tolerance test and ended up with quite a large sample size for the cohort. In comparison, my US sample size was 666 women and infants. But for the proposed study that we just finished, oh, sorry, one more slide. This one's an important one because in MASTI, we actually banked blood samples. So we have banked samples on 2,962 women, and we stored these thinking that there might be something of interest, like examining the maternal metabolome later in the study. So this was the focus of our study, where we actually were able to use some of those banked samples. So for the current study, we actually took a slightly different approach, where we did more of a case control. We took more of a case control approach, and we restricted our sample to 200 women, 110 delivered full-term infants, and 90 delivered preterm. And we restricted our sample for two reasons. First, we wanted to have 5-year outcomes on children, so that restricted us to about 500 women and infants, women and children. And then we had funding for about 200 total. So we sampled all preterm births within that 500, and then we matched with 110 full-term infants, leaving a total sample size of 200 for this analysis. So these are some demographic characteristics of women. And just to point out, we didn't actually see a lot of differences between full-term and preterm at enrollment. But just to highlight there, we didn't test to see if these were statistically significantly different, but I did want to highlight just a few that looked a little bit different. So women who delivered full-term infants had slightly less education levels than women who delivered preterm, which is interesting. We also looked at other maternal and infant characteristics, and just to highlight a few here, it looks like there may be some very slight differences in terms of depression in that women who delivered full-term infants, more women who delivered full-term infants had no depression or mild depression. And actually, these data are hot off the presses. And I was running some quick analyses over the past few days along with my colleagues, and we actually did see some differences with depression being the exposure and preterm birth being the outcome, but more on that soon. So we really struggled to get a contract set up with our metabolomics lab in India. I think I've set up many contracts through Johns Hopkins with vendors, outside vendors. This one won the award for taking the longest. It was almost a full year just getting this contract set up, and there were so many snafus and issues that we are actually still trying to get the lab paid. But everything's in place legally. We have our agreements, and we are just still struggling with some silly logistics, like getting their banking account information confirmed. But the lab ran our data, and we identified 1552 single metabolites through a global untargeted analysis of metabolites in pregnancy. Now, for those of you familiar, there's a fair amount of debate about whether to use an untargeted versus targeted approach with the metabolome, with metabolites. And for this project, we decided untargeted would be the best approach. Now, among those 1552 metabolites, about 92% were detected in 10% or more of the sample, and 544 were detected in all samples. So for the first analysis, we excluded those 544 in order to compare full-term versus preterm births. So we used Fisher's exact test to compare detection of each metabolite in our two groups, full-term versus preterm, and of course, excluding those metabolites where everyone had them. They were detected in all samples. And we adjusted for multiple testing because we had so many metabolites, as is expected with this type of research. We also used Wilcoxon rank sum tests to compare relative abundances, defined as the denominator is equal to the sum of abundances of 1552 metabolites included for a given subject. And this was in full term compared to preterm births, also adjusting for multiple testing. And I shared with our funders, but we basically got these data a few weeks ago. So we've been busy cleaning. And so I would like to add all appropriate caveats that these are very preliminary. And there's much more to come. So using Fisher's exact test and a Q of less than 0.05, which is accounts for multiple testing, we found 11 metabolites that were overly detected among those with preterm birth, and 27 metabolites that were overly detected among those with full-term births. So I'm in the process of drilling down to see the families of these metabolites and see if I can identify any patterns or the sources, the known sources of these various metabolites. But this is also unadjusted except for accounting for multiple testing. So next step is a fully adjusted model. And then using Wilcoxon-Rank sum tests and adjusting for multiple testing with a Q less than 0.05, we also found significant differences in the relative abundances for 212 metabolites between the two groups. So we have many, many next steps for this project. We will continue to clean and transform the data. We will conduct multivariable analyses in addition to our unadjusted crude analyses that we just ran. We will examine all metabolites in relation to all of our study outcomes, preterm birth, maternal depression, and child growth and development. And obviously, it's very important here with this type of research to interpret findings in the context of the literature and plan to draft manuscripts related to the aims and pursue additional external funding. I wanted to highlight very quickly a few of our milestones. We had an in-person meeting this past summer at the University of Colorado Anschutz Medical Campus in Colorado, in Aurora, Colorado. Dr. Mueller used to be faculty at Hopkins, and he's since moved to Colorado. So we all joined him there. And it was the first time one of our team members had been to the US. So she was very excited about that experience. We engaged a total of 2 master's, 2 doctoral, and 2 postdoctoral fellows in this research. And one of our team members successfully defended her PhD using MASTI data during this project. We are preparing a grant submission to Wellcome Trust and exploring other foundations. And then Dr. Mueller is actually traveling to attend an in-person launch of the Center for Developmental and Life Course Research in April. And he is bringing with him a suitcase full of packed supplies to pilot a new microbiome study of 250 children this summer and fall in a newly established tribal cohort in India. This is a quick picture of our in-person visit. I'd like to continue with a few other milestones. And one is that through this project, we submitted a proposal to launch a new center within the Public Health Foundation of India. And that center was approved last winter and will be launched, like I said, in April. And this center deepens our commitment to evidence-based health policy and implementation. It's got 2 focus areas: transforming our understanding of early life factors and health trajectories, and designing contextualized and innovative interventions, policies, and practices. You asked for a summary of financial utilization. The bulk of our budget went to the metabolomics lab, and a few thousand contributed to 0.5% of my salary, and then we had travel funds in the budget. And these funds were supplemented by other monies I was able to pull in from other projects to support travel, to support some of the other things related to this project. So we did contribute some additional funds. So thank you. I apologize for having technical difficulties this morning, and I'm interested to see if you have any questions.
Thank you so much, Sarah. That was fantastic. I did not know about the cohort. Interestingly enough, one of my former mentees, who's now at Cornell, has actually been doing a gestational diabetes cohort in Pune with an NGO, and sort of really looking at sort of the integration of screening and in community sort of women who are pregnant. So it'd be great to connect you. It's an R01 funded study, an implementation science study, actually. So
Great.
look forward to also seeing your follow-up results when you have all your data completed. But very interesting that also the Public Health Foundation is setting up a full center really dedicated and focused on sort of doing implementation science. So that's terrific. We'll open
This
up the
project was pivotal in establishing that center,
yeah, that's
demonstrating.
fantastic. It sounds like it will also create a lot of new opportunities for the collaboration.
Yes.
So we'll open it up for any questions or comments for Sara. Feel free to put your questions or chat or unmute yourself. Quiet group. So out of curiosity, having done some of these metabolomic sort of exercises and going through even the analytics and the like, since there's so many different drivers of preterm birth, or at least, purported to be, I mean, did you really feel that there would be some common metabolomic signature? Because I saw that in your background you had some data to support that there would be. And so, was there a specific hypothesis, or was it sort of truly sort of untargeted discovery?
Yeah, that's a great question. I would say this was truly an untargeted. We were very much informed by this Kinshuk article in 2023 that looked at the vaginal metabolome, because
Mhm.
they had a very small sample size as well, and they were focused on Black and white women in the US. So a different, very different cohort, but they did identify four metabolites that were higher in preterm birth. And the interesting thing is that three of those four metabolites are from exogenous sources. So things like environmental exposure, which are important risk factors for pregnancy. And then the other one was not an exogenous source. So exogenous sources are things that can come from the environment, from food additives, from cosmetics, and these are fairly modifiable. And so that was our approach here, is that, and the authors argued in this article, is that they argued that you can actually use metabolome-based models to predict spontaneous preterm birth months in advance if you're able to identify certain key metabolites in pregnancy. And exposure to these endocrine disrupting chemicals, like I said, it's potentially modifiable. So it's really identifying, of the metabolites that are higher in preterm birth, which ones are from exogenous sources. Where can we actually intervene and try to reduce exposure? So even though it was very exploratory, we were very mindful of examining metabolites from exogenous sources, and with the interest of clinical intervention.
That's terrific. And this lab that you identified, this was based after reviewing several different potential laboratory sites in India that does metabolomics.
That's right. So we selected Kemp because the samples were not allowed to leave the country, and which is absolutely understandable. And then our colleague, Dabarati Mukherjee, she had an established relationship, and Deepa Ravi, who was the doctoral student who is now has her PhD and is part of the team, they had an established relationship with this lab, Camp. So for us, it was absolutely an excellent choice because they had such a good relationship, and the others were just we knew of the other available labs, but we didn't know them.
Yeah, yeah. Yeah, no, it'll be interesting because we've used a few different labs and not this one, so it'd be good to learn more. All right, well, I've done a lot of talking. Anybody else in the group have any questions or comments? All right, well, hearing none, thank you so much for these wonderful updates. Dr. Nishi and Dr. Sara, that was terrific, really great presentations. And nice to see the work sort of come to this point. Over to you, Megashish.
So that's it from our side. We are grateful to our project teams for their groundbreaking research for now, and we will be in touch regarding the next steps, and we will have to learn more about your work in the future. So with that, I think we can close today's session. A very warm thank you to all our attendees who've taken out the time. I'm grateful to Dr. Amita for her leadership and guidance, Dr. Nishi for sharing your work, and as well as Dr. Sara for showing you. So, as well as Dr. Christopher Kemp. So, thank you all. We can close the session now.
Terrific. Thank you all.
Thank
Thank
you.
you, everyone.